Good day. Today we'll be discussing on liver physiology with focus on the transport and metabolic functions of the liver. I am Dr. Enric Aguila, a gastroenterologist. Here are the learning objectives for this session. We describe the physiologic anatomy of the liver, the hepatic vascular system and its function, metabolic function of the liver in carbohydrate, lipid, and protein metabolism. We describe the bilirubin production and secretion, discuss the composition and function of bile, and describe the excretion of bilirubin in the bile. To start off, the liver is a large multi-lobed organ located in the abdominal cavity. It is the first site of processing for most absorbed nutrients. It supplies most of the plasma proteins and synthesizes the bile that optimizes in the absorption of fats. Also, it is considered a metabolic powerhouse, which is critical for disposing variety of metabolic waste products and xenobiotics from the body by converting them to forms that can be excreted. It also stores or produces numerous substances needed by the body, such as glucose, amino acids, and plasma proteins. We first discuss on the structural features of both the liver and the biliary system. For review, the liver has two lobes, the right and the left. Each lobe is made up of thousands of hexagonally shaped lobules, as shown in the image. These lobules are very small, and it is based on the physical organization of structures within the liver, with a central vein at its center and portal areas at its peripheral corners. The hepatic lobule is considered the anatomic unit of the liver. Each hepatic lobule is made up of numerous liver cells called hepatocytes that line up in radiating rows and are one cell thick. The acinus, on the other hand, is considered the functional unit of the liver. While the hepatic lobule pertains more on the physical structure, the acinus is based more on function. It is shown in the purple areas in the image, and it encompasses the liver tissue that is served by a single terminal branch of the hepatic artery. Hepatocytes are the major cell type in the liver, and they are arranged in anastomosing cords that form plates around which large volumes of blood circulate. Blood from the intestines and other viscera reach the liver via the portal vein. This blood percolates in sinusoids between the hepatic cells and eventually drains into the hepatic veins, which in turn empty into the inferior vena cava. As shown in the schematic diagram, hepatocytes are arranged radially in plates surrounding a central vein. Blood is supplied to the liver by branches of the portal vein and hepatic artery, which empty into sinusoids surrounding the hepatocytes. The direction of blood flow is indicated with black arrows. Plates of hepatocytes that constitute the liver parenchyma are supplied by a series of sinusoids as indicated by the blue channels in this image. They are low resistance cavities supplied by branches of both portal vein and hepatic artery. During fasting, many sinusoids are collapsed, but more can gradually be recruited as portal blood flow increases during the period after a meal when absorbed nutrients are transported to the liver. Blood drains into central branches of the hepatic vein. Hepatic artery blood also enters the sinusoids. Bile is formed on the other side of the plate. The average transit time for blood across the liver lobule from the portal venule to the central hepatic vein is about 8.4 seconds. In each hepatic lobule, the plates of hepatic cells are usually only one cell thick. In this image, note that there are also wide openings called fenestrations between the endothelial cells next to the hepatocytes. These fenestrations permit passage of molecules. Plasma is in intimate contact with these cells. In addition, as you can see with the green circles here, each liver cell is opposed to several bile canaliculi, which I'll discuss in detail later on. Going back to the acinus, which is the functional unit of the liver, again, you see it here in the purple colored area of the hepatic lobule. It is a unit that contains a small portal tract at the center and terminal hepatic venules at the periphery, with a single terminal branch of the hepatic artery. It is the smallest functional unit and is divided into zones 1, 2, and 3. Zone 1, or the periportal zone, surrounds the portal tract and is the central portion of the acinus where the hepatocytes are lying closest to the triad. Given that it is in proximity with the hepatic triad, it has the greatest supply of oxygen and nutrients and is the most active in detoxification functions in normal circumstances. However, it is more sensitive to oxidative injury. Zone 2, or the intermediate zone, is between Zone 1 and 3 and is moderately well oxygenated. Finally, Zone 3, or the peripheral zone, surrounds the hepatic venule or the central vein. It is most sensitive to ischemia given that it is farthest to the hepatic triad. It is most active in bile acid synthesis. Aside from the hepatocytes, there are other highly specialized cells in the liver playing particular functions. The hepatic endothelial cells line the wall of sinusoids, and it contains fenestrations that are large enough to permit passage of molecules as big as albumin. They lack a basement membrane and allow access of albumin-bound substances to the hepatocytes that will eventually take them up. Kupffer cells, on the other hand, are liver-resident macrophages localized within the lumen of liver sinusoids and are anchored to the endothelial cells. It traps and breaks down bacteria and other particulates. The space of this is a thin layer of loose connective tissue beneath the sinusoidal endothelium, which separates the endothelium from the hepatocytes. It poses little resistance to movement of molecules even as large as albumin. It is also the location of stellate cells. So the stellate cells, also known as Ito cells, normally residing in the sinusoidal walls within the space of this, serve as storage sites for retinoids or vitamin A and serves as a source of key growth factors for hepatocytes. Under abnormal conditions, stellate cells are activated to synthesize large quantities of collagen, which contribute to hepatic dysfunction. We go to the biliary system. As earlier mentioned, each liver cell is opposed to several bile canaliculi. These canaliculi then drain into the intralobular bile ducts, and these coalesce via the interlobular bile ducts to form the right and left hepatic ducts. Kindly refer to this image. The right and left hepatic ducts contain join to form the common hepatic duct. The hepatic duct then unites with the cystic duct to form the common bile duct. The common bile duct enters the duodenum at the duodenal papilla. Its orifice is surrounded by the sphincter of Oddi, and it usually unites with the main pancreatic duct just before entering the duodenum. The sphincter is usually closed, but when the gastric contents enter the duodenum, cholecystokinin or CCK is released, and the hormone relaxes the sphincter and makes the gallbladder contract. Walls of the extrahepatic biliary ducts and the gallbladder contain fibrous tissue and smooth muscle. It is lined by a layer of columnar cells known as cholangiocytes with scattered mucous glands. In the gallbladder, surface is extensively folded, increasing its surface area and gives the interior a honeycombed appearance. Cystic duct is also folded to form the spiral valves, also known as the valves of Heister. This arrangement is believed to increase the turbulence of bile as it flows out of the gallbladder, thereby reducing the risk that it will precipitate and form gallstones. Blood from the portal vein and hepatic artery percolates around the hepatocytes by the sinusoids before draining into the central vein. The liver receives high blood flow that is disproportionate to its mass, which ensures that hepatocytes receive high quantities of both oxygen and nutrients. Hepatocytes receive more than 70% of their blood supply at rest via the portal vein, and this could rise to more than 90% in the postprandial period. As discussed earlier, these intrahepatic branches of the hepatic artery and portal vein converge on the sinusoids and drain into the central lobular veins of the liver. Collectively, branches of the hepatic vein, hepatic artery, and bile ducts run in parallel, and this is called the hepatic triad. If the circulation of the liver is compressed by fibrosis, the liver loses its ability to accommodate the increases in blood flow that occur after a meal without a concomitant increase in pressure. This increase in pressure can result to ascites as shown, and it is albumin escaping from the circulation through the fenestrations in the hepatocytes. The albumin-rich fluid weeps from the surface of the liver into the abdominal cavity, where it overwhelms the lymphatic drainage. As the pressure of the liver builds, new collateral blood vessels form in an attempt to circumvent the obstruction and reduce the portal hypertension. Some of these vessels are directed to abdominal structures and because of their thin, weak walls are prone to rupture. A particular example is formation of high-pressure collaterals to the esophagus, which can become varices that bleed into the lumen. In effect, formation of collateral blood vessels bypasses the remaining metabolic capacity of the liver, and levels of toxins such as ammonia are increased and can exert adverse effects in the body. Infection of the liver with certain viruses or exposure to toxic substances such as alcohol kills hepatocytes and activates hepatic stellate cells, which synthesize excessive amounts of collagen that result in the histologic appearance of fibrosis. Cirrhosis is the state when liver fibrosis becomes irreversible if the insult is already chronic. The fibrotic scarred areas crowd out the hepatocyte mass, thereby reducing the synthetic, metabolic, and excretory capacity of the liver. Fibrotic masses press on the sinusoids and prevent them from expanding as portal blood flow to the liver increases during the postprandial period. Cirrhosis can result to edema as a result of reduced levels of albumin in blood. Ascites due to fluid accumulation in the peritoneal cavity secondary to increased portal pressure. Eventually, accumulation of toxic substances in the bloodstream can lead to jaundice, itching, and urologic complications. If hepatic function becomes compromised beyond a certain level, the only effective treatment is liver transplantation. The principal functions of the liver mainly include formation and secretion of bile, nutrient and vitamin metabolism, inactivation of various substances such as toxins, steroids, or other hormones, and includes detoxification and excretion of waste products. Synthesis of plasma proteins such as the acute phase proteins, albumin, clotting factors, and immunity with the presence of Kupffer cells. As for the metabolic functions of the liver, hepatocytes mainly contribute to the metabolism of the major nutrients, mainly carbohydrates, lipids, and proteins. It serves an important role in glucose metabolism and as storage of glycogen. The so-called glucose buffer function of the liver maintains the stability of blood glucose levels in the postprandial period, releasing excess glucose from the blood and returning it as needed. This is observed by glycogenesis, or the breakdown of glycogen into glucose, glycogenolysis, or the formation of glycogen from glucose, and gluconeogenesis, or the formation of glucose from non-carbohydrates, fats, and proteins. When hepatic function is impaired, blood glucose concentrations may rise excessively after ingestion of carbohydrates, or hypoglycemia between meals because of an inability of the liver to contribute to carbohydrate metabolism and interconversion of one sugar to another. Lipid metabolism also occurs in the liver with rich source of metabolic enzymes engaged in fatty acid oxidation to supply energy for other body functions. These enzymes also convert products of adipose tissue and synthesize large quantities of lipoproteins, cholesterol, and phospholipids, the latter two being important in the biogenesis of cell membranes. Finally, hepatocytes can also convert a considerable portion of synthesized cholesterol to bile acids. Protein is also metabolized in the liver. The liver is the site of synthesis of non-essential amino acids that do not need to be supplied in the diet. Likewise, it participates in interconverting and deaminating amino acids so the products can enter biosynthetic pathways for carbohydrate synthesis. With the exception of immunoglobulins, the liver synthesizes almost all the proteins present in plasma, especially albumin, which determines plasma oncotic pressure, as well as most clotting factors. Hence, those with liver disease may develop peripheral edema secondary to hypoalbuminemia. Finally, the liver is a critical site for disposal of the ammonia generated from protein catabolism. This is accomplished by converting ammonia to urea, which is excreted by the kidneys. The liver has an important role in detoxification of substances. It serves both as a gatekeeper by limiting entry of toxic substances into the bloodstream and as a garbage disposal by extracting potentially toxic metabolic products produced elsewhere in the body and converting them to chemical forms that can be excreted. Majority of blood arriving at the liver is venous in nature and is supplied by the portal vein from the intestine. As such, the liver is strategically located to receive both absorbed nutrients and potentially harmful absorbed molecules such as drugs and bacterial toxins. Little or none of absorbed substances may make it into the systemic circulation depending on the efficiency which the molecules are extracted by hepatocytes and subjected to first pass metabolism. This is the reason why not all pharmaceutical agents can achieve therapeutic concentrations in the bloodstream if administered orally. The liver has two levels for detoxification. The first level of defense is physical, with the blood arriving in the liver percolating among Kupffer cells. These Kupffer cells, as discussed earlier, are phagocytic and removes particulate matter from portal blood, including bacteria that may enter blood from the colon even under normal conditions. The second level of defense is biochemical, wherein enzymes in the hepatocytes modify both endogenous and exogenous toxins so the products are in general more water soluble and less susceptible to uptake by the intestine. There are two phases by which this occur. Phase 1 reactions include oxidation, hydroxylation, and other reactions catalyzed by cytochrome P450 enzymes. This is followed by phase 2 reactions, where the products are conjugated with another molecule, for instance, amino acids, glutathione, or glucuronic acids, and this promotes their excretion. Finally, the products of these reactions are then excreted into bile or returned to the bloodstream to ultimately be excreted by the kidneys. Liver also plays a role in the excretion of waste products. Larger water-soluble catabolites and molecules bound to plasma proteins, including lipophilic metabolites and xenobiotics, steroid hormones, and heavy metals, cannot be filtered by the glomerulus. These substances are excreted in bile. The substances excreted in bile are exported across the canalicular membrane of hepatocytes via a different array of transporters as shown in the table below. A feature of the bile is that it allows solubilization of even lipophilic substances, which can then be excreted into the intestine and ultimately leave the body in feces. Bile is an excretory fluid produced in the liver that plays an important role in lipid digestion. So bile primarily performs two functions. Number 1, to carry away waste. Number 2, break down fats during digestion. Its formation begins in hepatocytes as end products of cholesterol metabolism, which actively transport solutes into bile canaliculi across their apical membranes. The micellar solution is composed of major solutes, bile acids, phosphatidylcholine, and cholesterol at a 10:3:1 ratio respectively. The secretion of solutes drives concomitant movement of water and electrolytes across the tight junctions that link adjacent hepatocytes to form canalicular bile. Majority of bile flow is driven by the secretion of bile acids across the tight junctions that link the adjacent hepatocytes. This is mediated by transporters, one of which is the bile salt export pump, or the BSEP, which is an ATPase transporter that aids in the majority of bile flow as driven by the secretion of bile acids across the apical membrane of hepatocytes. Ultimately, bile becomes a concentrated solution of biological detergents that aids in solubilization of the products of lipid digestion in the aqueous environment of the intestinal lumen, thereby enhancing the rate at which lipids are transferred to the absorptive epithelial surface. It also serves as a medium in which metabolic waste products are exported from the body. With regards to transporters, there is a variety of rare familial syndromes involving its mutations. Type 2 progressive familial intrahepatic cholestasis or PFIC is the mutation in BSEP that results in an almost a total absence of bile acids in the bile. Cholestasis develops, but with relatively little, if any, evidence of bile duct injury. In type 3 PFIC, the mutations result through absence of multi-drug resistance protein 3 or MDR3 and phosphatidylcholine is no longer able to enter the bile. This is more aggressive, in which cholestasis is accompanied by early increases in circulating GGT. As discussed earlier, bile is made up of bile acids, bile pigments, and other substances dissolved in an alkaline electrolyte solution that resembles pancreatic juice. So about 500 ml of bile is secreted per day. In terms of its synthesis, the initial and rate-limiting step is addition of a hydroxyl group to the 7 position of the steroid nucleus by the enzyme cholesterol 7 alpha hydroxylase. Bile acid synthesis can be up or down regulated depending on the body's requirements. For instance, if bile acids are reduced in the blood flowing to the liver, synthesis can be up to tenfold. They activate a variety of cell surface and nuclear receptors in hepatocytes that lead to activation of specific transcription factors that regulate enzyme abundance. Primary bile acids are synthesized by the hepatocyte and include chenodeoxycholic acid and cholic acid. Each can actually be metabolized in the colonic lumen by bacterial enzymes to yield ursodeoxycholic acid and deoxycholic acid. On the other hand, chenodeoxycholic acid is converted by bacterial enzymes to form dithocholic acid, which is relatively cytotoxic. The orso-deoxycholic acid, deoxycholic acid, and lithocholic acids are secondary bile acids. Conjugation of the bile acids then follows. The primary and secondary bile acids in the hepatocyte are conjugated with either glycine or taurine, resulting to bile acids being almost totally ionized at the pH prevailing in the small intestinal lumen and thus cannot passively traverse cell membranes. Conjugated bile acids are retained in the intestinal lumen until they are actively absorbed in the terminal ileum via the apical sodium-dependent bile salt transporter or the ASBT. Conjugated bile acids that escape this uptake step are deconjugated by bacterial enzymes in the colon, and the resulting and conjugated forms are passively reabsorbed across the colonic epithelium. Bile acids assist in digestion and absorption of lipids by acting as detergents rather than enzymes, and thus significant mass of these molecules is required to solubilize all dietary lipids. Through the enterohepatic circulation, conjugated bile acids are all actively reabsorbed and travel through the portal blood back to the hepatocyte, where they are efficiently taken up by the basolateral transporters. Bile acids that are deconjugated in the colon also return to the hepatocyte, where they are reconjugated to be secreted into bile. And this way, a pool of circulating primary and secondary bile acids is produced, and daily synthesis is then equally only to the minor fraction that escapes uptake and is lost in the stool. The only exception is lithocholic acid, which is preferentially sulfated in the hepatocyte rather than being conjugated with glycine or taurine. We now discuss the gallbladder. Going back to the flow of bile, it enters the ducts and is conveyed toward the intestine. However, in the period between meals, outflow is blocked by constriction of the sphincter of Oddi, and thus bile is redirected to the gallbladder. During gallbladder storage, bile becomes concentrated because sodium ions are actively absorbed in exchange for protons and bile acids, as the major anions are too large to exit across the gallbladder epithelial junctions. Although the concentration of bile acids can rise more than tenfold, bile remains isotonic because a single micelle acts as only one osmotically active particle. Any additional bile acid monomers that become available as a result of concentration are thus immediately incorporated into existing mixed micelles. This reduces the risk that cholesterol will precipitate from bile. Bile is secreted from the gallbladder in response to signals that simultaneously relax the sphincter of OD and contract the smooth muscle that encircles the gallbladder epithelium. This secretion is mediated by cholecystokinin and the intrinsic neural reflexes and vagal pathways. The net result is ejection of a concentrated bolus of bile into the duodenal lumen, where the constituent mixed micelles can aid in lipid uptake. When no longer needed, the bile acids are reclaimed and re-enter the interhepatic circulation to begin the cycle again. Other components of bile are largely lost in the stool, thus providing for their excretion from the body. Gallstones represent bile constituents that accumulate in the gallbladder or elsewhere in the biliary tree. It is composed predominantly of cholesterol or calcium bilirubinate or pigment stone. It can obstruct biliary flow and thereby result in pain, poor tolerance of large fatty meals, retention of biliary constituents, and if left untreated, liver injury. In susceptible individuals, mechanisms that normally prevent nucleation of saturated bile are either defective or overcome, and small crystals form and can grow into gallstones. Bile can be supersaturated in terms of cholesterol content, increasing the risk of stone formation, particularly during prolonged fasting. Cholesterol gallstones are common in middle-aged women who are obese, particularly those who have born children. The mnemonic we often use for these risk factors is F4, or the fat, fertile, female, and 40. This increased prevalence is largely in part due to the ability of estrogen to increase hepatic cholesterol secretion in this population group. In terms of treatment, if symptomatic or in severe cases of gallstone disease, laparoscopic cholecystectomy is recommended. ERCP or endoscopic retrograde cholangiopancreatography is recommended for endoscopic retrieval of small gallstones if they have lodged in the biliary tree. The liver is also important for excretion of bilirubin, which is a metabolite of heme that is potentially toxic to the body. Bilirubin is an antioxidant and allows for the elimination of the excess heme released from the hemoglobin of senescent red blood cells. RBCs account for 80% of bilirubin production, with the remainder coming from additional heme-containing proteins in other tissues, such as skeletal muscle and the liver. Bilirubin can cross the blood-brain barrier, and if present in excessive levels, results in brain dysfunction secondary to neuronal cell death and the activation of astrocytes and microglia. This can be fatal if left untreated. Bilirubin and its metabolites provide color to bile, feces, and to a lesser extent the urine. It is also responsible for jaundice or the yellowing of the skin and conjunctiva when it accumulates in the circulation as a result of liver disease. Bilirubin is synthesized from heme by a two-stage reaction that takes place in the phagocytic cells of the reticuloendothelial system, including Kupffer cells and the cells in the spleen. The enzyme heme oxygenase that is present in these cells liberates iron from the heme molecule and produces the green pigment biliverdin. This in turn can be reduced to form the yellow bilirubin. Because bilirubin is essentially insoluble in aqueous solutions at neutral pH, it is transported through the bloodstream bound to albumin. When this complex reaches the liver, it enters the space of this, where bilirubin is selectively taken up across the basolateral membrane of hepatocytes via an OATP transporter. In the microsomal compartment, bilirubin is then conjugated with one or two molecules of glucuronic acid to enhance its aqueous solubility. The reaction is catalyzed by the UDP glucuronyl transferase or UGT, and thus UGT is synthesized only slowly after birth. So, which explains why mild jaundice is relatively common in newborn infants. Bilirubin conjugates are then secreted into bile by a multi-drug resistance associated protein or MRP2 located in the canalicular membrane. At this point, conjugated forms of bilirubin cannot be reabsorbed from the intestine, thereby ensuring they can be excreted. Both conjugated and unconjugated bilirubin circulate bound to albumin, but the conjugated form is bound more loosely and thus can enter the urine. In the colon, bilirubin conjugates are deconjugated by bacterial enzymes, whereupon the bilirubin liberated is metabolized by bacteria to yield urobilinogen, which is reabsorbed, and urobilins and stercobilins, which are excreted. Absorbed urobilinogen can be taken up by hepatocytes and reconjugated, giving another chance to be excreted. Measurement of bilirubin in plasma is an important tool in the evaluation of liver disease. So, unconjugated hyperbilirubinemia occurs when fully albumin bound and cannot be excreted in urine. Reflects either loss of UGT or a normal temporary delay in its maturation in infants, or a sudden oversupply of heme that overwhelms the conjugation mechanism, such as occurs in transfusion reactions or in rhesus incompatible newborns. Conjugated hyperbilirubinemia, on the other hand, is characterized by the presence of bilirubin urine, to which it imparts a dark coloration. This is indicative of genetic defects in the transporter that mediates bilirubin glucuronide or diglucuronide secretion into the canaliculus, or it may be due to blockage to the flow of bile caused by an obstructing gallstone. Well, in both cases, bilirubin conjugates are formed in the liver, but with no means of exit, they regurgitate back into plasma for urinary excretion. For the clinical correlate, we discuss Crigler-Najjar syndrome. As discussed earlier, conjugation of bilirubin is catalyzed by UDP glucuronyl transferase or UGT. The Crigler-Najjar syndrome is a condition associated with mutations in the hepatocyte enzyme UGT. The mutation impairs the ability of hepatocytes to conjugate bilirubin. Hence, the unconjugated bilirubin regurgitates back to circulation and binds to albumin, with an associated risk of neurological injury if levels rise precipitously. There are two types, with type 1 due to a congenital missense mutation, resulting in complete lack of the enzyme, and the treatment for this is liver transplantation. Type 2, on the other hand, is a milder mutation that reduces UGT levels to about 10% of the normal range, thus with varying degrees of severity. As for its treatment, it is sometimes managed effectively with blue light. This converts circulating unconjugated bilirubin to forms that are more water-soluble and thus less firmly bound to albumin, which can be excreted in the urine. The liver is also critical for disposing ammonia, as it can be toxic if accumulates in the bloodstream. Ammonia is a small neutral metabolite that arises from protein catabolism and bacterial activity and is highly membrane permeant. It readily crosses cell membranes without the benefit of a specific transporter. The liver is a critical contributor to prevention of ammonia accumulation in the circulation, which is important because ammonia is toxic to the central nervous system and freely permeable across the blood-brain barrier. The liver eliminates ammonia from the body by converting it to urea via a series of enzymatic reactions known as the urea cycle or Krebs-Henseleit cycle. Ammonia is derived from two major sources, namely the colon and the kidney. So approximately 50% is produced in the colon by bacterial ureases. 40% is produced in the kidney, while the remaining 10% is derived from the amination of amino acids in the liver by metabolic processes in muscle cells and via release of glutamine from senescent red blood cells. Because the colonic lumen is normally slightly acidic, some of this ammonia is converted to the ammonium ion, which renders it impermeant through the colonic epithelium and therefore allows it to be excreted in stool. The remainder of the ammonia generated crosses the colonic epithelium passively and is transported to the liver via the portal circulation. As ammonia passes through the liver, almost all of the ammonia in the circulation is carried into the hepatocytes. A series of subsequent cytoplasmic reactions eventually produce arginine, and this can be dehydrated to urea and ornithine. The physicochemical properties of ammonia ensure that it is efficiently extracted from portal and systemic circulation by hepatocytes, where it then enters the urea cycle to be converted to urea and is subsequently transported back into the system circulation. Urea is readily filtered at the glomerulus, and it is reabsorbed by the kidney tubules such that approximately 50% of the filtered urea is excreted in urine. Urea that enters the colon is either excreted or metabolized to ammonia via colonic bacteria, with the resulting ammonia being reabsorbed or excreted. If the metabolic capacity of the liver is compromised acutely, coma and death can rapidly ensue. If ammonia and other toxins cannot be cleared by the liver in patients with chronic liver disease, hepatic encephalopathy can occur when patients experience a gradual decline in their mental function. Development of confusion, dementia, and eventually coma in a patient with liver disease is evidence of significant progression, and these symptoms can prove fatal if left untreated. And finally, for the clinical part, last part of this lecture, we discuss the clinical assessment of liver function. We often order liver tests mainly because of any of these three reasons. Number one, to assess whether hepatocytes have been injured or are dysfunctional. Number two, to determine whether bile excretion has been interrupted. And number three, to evaluate whether cholangiocytes have been injured or are dysfunctional. Well, in a more layman's term, you can refer to this image. We order it to check for damage from liver infections or diseases, to monitor side effects of medications, to assess treatment for a disease, to diagnose symptoms of a liver disease, and to check for liver damage from heavy alcohol use. It is also used to monitor responses to therapy or rejection reactions after liver transplant. However, it is important to note that not all such tests really measure function directly. So hence, it is better to call liver function test as liver biochemical test for this reason. Tests for hepatocyte injury include the ALT and AST. When hepatocytes are killed by necrotic responses to inflammation or infection, they release enzymes that include alanine aminotransferase or the ALT and aspartate aminotransferase or the AST. These enzymes are easily measured in serum and indicate hepatocyte injury. Although AST may also be released after injury to other tissues, including the heart. Tests for injury to the biliary system include the alkaline phosphatase and the GT. Alkaline phosphatase is expressed in the canalicular membrane, and elevations of this enzyme is plasma suggested localized obstruction to bile flow. Similarly, increased levels of GGT are seen when there is a damage to cholangiocytes. Measurement of bilirubin in the circulation or in urine also provides insight into liver function. Serum albumin and prothrombin time can also be requested as it aids in the diagnosis of liver disease. If both are deranged and compatible with the clinical picture of the patient, a diagnosis of liver disease may be established. Blood glucose and ammonia levels are monitored in patients with chronic liver disease. And finally, imaging tests and biopsy results are also important in evaluating and monitoring patients with suspected or proven liver disease, although it's not always indicated among patients with the liver disease. And to conclude this lecture, we have the following key concepts to summarize. Vital function of the liver include carbohydrate, lipid, and protein metabolism and synthesis, detoxification of unwanted substances, and excretion of circulating substances that are lipid soluble and carried in the bloodstream bound to albumin. The liver also synthesizes the majority of plasma proteins, including albumin. Liver function depends on its unique anatomy, its constituent cell types, especially the hepatocytes, and the unusual arrangement of its blood supply. Substances are excreted from the liver in bile. Bile flow is driven by the presence of bile acids, which are amphipathic and products of cholesterol metabolism that are produced by hepatocytes. Bile acids circulate between the liver and intestine to conserve their mass, and water-insoluble metabolites are carried in bile in the form of mixed micelles. Bile is stored in the gallbladder between meals, where it is concentrated and released when hormonal and neural signals simultaneously contract the gallbladder and relax the sphincter of Oddi. Lastly, the liver is critical for disposing of certain substances that would be toxic if allowed to accumulate in the bloodstream, including bilirubin and ammonia. This lecture is mainly lifted from the Byrne-Levy, Ganong, and Guyton and Hall. Thank you very much for listening.